Hi, I'm Michael Fricker and I'm a research fellow based at the University of Newcastle and Hunter Medical Research Institute in New South Wales, Australia. Today, on behalf of my co-authors, I'm going to present a brief summary of our recently published manuscript titled Mepolizumab depletes inflammatory but preserves homeostatic eosinophils in severe asthma. Eosinophils are key therapeutic targets in severe asthma and are targeted by IL-5 pathway biologics that block either the cytokine or the receptor. Recently, eosinophil subsets have been described, including inflammatory eosinophils and homeostatic eosinophils. Mouse studies suggest that inflammatory eosinophils are induced in asthma-like disease and play a pathogenic role, while homeostatic eosinophils are ever present in lung and circulation and have a more immunomodulatory role. The clinical associations of eosinophil subsets and the relative impact of IL-5 pathway biologics on these subsets are unknown. To address this, we performed an observational clinical study. In a cross-sectional study, we recruited 80 adult participants with severe asthma, comparing outcomes across non-eosinophilic, eosinophilic, and mepolizumab-treated severe asthma. Of the 32 participants with eosinophilic asthma in the cross-sectional study, we followed up 30, 20 of whom commenced mepolizumab treatment and 10 who commenced benralizumab after the first study visit. These participants were followed up at 8 weeks and 24 or more weeks following the commencement of their treatment. Blood inflammatory and homeostatic eosinophils were assessed by flow cytometry using surface CD62L protein expression, and blood eosinophil viability was also assessed using this method. On to the main results. Eosinophil subset proportions varied between patients. We noted that increased inflammatory eosinophil proportion was correlated with poorer asthma control in biologic-naive eosinophilic asthma patients, and the inverse was observed with homeostatic eosinophils. In the cross-sectional study, we noted that a lower proportion of total eosinophils were classified as inflammatory eosinophils in mepolizumab-treated participants. Both mepolizumab and benralizumab almost completely depleted circulating inflammatory eosinophils in the longitudinal study. In contrast, a significantly greater number of homeostatic eosinophils remained after 8 weeks and 6 months of mepolizumab treatment compared to benralizumab, which fully depleted homeostatic eosinophils. In mepolizumab-treated patients, we found that lower residual inflammatory eosinophil burden was correlated with better asthma control. In addition, we observed the appearance of dead eosinophils by flow cytometry in a subset of patients that were treated with mepolizumab. These mepolizumab-treated patients with dead eosinophils that were detectable had better clinical outcomes, including better asthma control and lung function. To conclude, we believe that eosinophil phenotype measures, including eosinophil subsets and viability, may offer improved means to monitor response to anti-IL-5 therapy in severe asthma, and these merit further investigation. I'd like to thank you for your attention, and I'd be happy to take any questions about the study by email.